Hello everyone. In this lecture, we are going to discuss about the process of normal hematopoiesis. So first, we'll discuss what are the sites of normal hematopoiesis. The first blood cell progenitor is going to appear in the yolk sac. It is going to appear in the yolk sac in the third week of intrauterine life. However, this is only for a transient period. After few weeks, the definitive hematopoietic stem cells are going to appear in the mesoderm surrounding the aorta, gonads, and mesonephros. Okay. The first cells appear in the yolk sac, and after few weeks, definitive hematopoietic stem cells are going to appear in the mesoderm surrounding aorta, gonads, and mesonephros. Then, in the third month of intrauterine life, the hematopoietic stem cells will migrate and populate liver and to a lesser extent spleen also. Okay. So in the second trimester of pregnancy, in the fetus, liver is the predominant site in which the hematopoiesis is happening. Okay. And liver will continue to produce hematopoietic cells up to birth. Okay. So it is going to produce the blood cells till birth. What happens in fourth month of life? In fourth month of life, some of the hematopoietic stem cells will also go and populate the bone marrow. They will go and populate the bone marrow. So bone marrow will also contribute to the process of hematopoiesis starting from the fourth month of life. And we need to understand after birth, okay, after birth, only bone marrow is going to produce the blood cells under normal circumstances. Okay, so after birth, it is only the bone marrow which is going to produce the blood cells. Okay, and the one more point is after birth, all the bone marrow in our body, they are active. Okay, so just after birth, all the bone marrow in our body has hematopoietic activity. However, after puberty, the process of hematopoiesis is limited only to axial skeleton. It is limited only to the axial skeleton and the proximal parts of femur and humerus. Okay. So after birth, all the bone marrows are active, but after puberty, active bone marrows you will only find in axial skeleton and the proximal parts of femur and humerus. The active bone marrow is otherwise known as the red bone marrow, and the inactive bone marrow is otherwise known as the yellow bone marrow. It is known as the yellow bone marrow. Okay, so from this discussion, you can understand after birth, just after birth, 100% of the bone marrow are red bone marrow. Okay, after birth, 100% of the bone marrow are red bone marrow, and after puberty, that means in the adult life, at least 50% of the bone marrow are red and 50% are yellow bone marrow. Okay, so in adults, half of the bone marrow space is hematopoietically active. Okay, so this concept is clear. Now, next point is some of the hematopoietic stem cells during the intrauterine life will also populate the fetal placenta. However, this doesn't have much physiological role. That means in the process of normal physiological hematopoiesis during intrauterine life, these hematopoietic stem cells which are resident in the fetal placenta, they will not contribute much. Okay, so it doesn't have much of physiological role. However, it has a very important clinical significance. Now we know that hematopoietic stem cell transplantation can also be done from hematopoietic stem cells which are collected from the umbilical cord blood of a newly born infant. Okay, so you can collect the hematopoietic stem cells from the umbilical cord of a newly born infant, and those hematopoietic stem cells can be used for hematopoietic stem cell transplantation, and those stem cells are thought to come from this fetal placenta. Okay, so there is the clinical significance of this. Okay. Next concept is now we know that some of the cells from the yolk sac. Okay, I told you yolk sac will produce hematopoietic cells only in the initial stages, that is around the 3rd and 4th week of life. And I told you this is only for a transient period. They will just produce some of the embryonic hemoglobins, which doesn't have much significance. But it is thought that some of the cells from this yolk sac are going to become permanent tissue macrophages. They are going to become permanent tissue macrophages, like the microglial cells in the brain, like the Kupffer cells in the liver. So we'll discuss all those macrophages later. But understand that some of the cells from the yolk sac are going to become tissue macrophages in the adult life also. Okay, and the other source for tissue macrophages is the monocytes. Okay, monocytes are a type of WBCs, which when go from the circulation into the tissues, they will be converted to the macrophages. Okay, so tissue macrophages, they are either derived from the yolk sac or they are derived from the monocytes. Okay, they are derived from the monocytes. So these are the important concepts about this sites of normal hematopoiesis. Okay, so I'll just recap it again. So the first blood cell progenitors, they appear in the yolk sac in the 3rd week of intrauterine life. Some of the cells of yolk sac will produce tissue macrophages. After a few weeks, mesoderm surrounding outer gonads and mesonephros, they will carry the definitive hematopoietic stem cells. In the 3rd month of life, hematopoietic stem cells will populate the liver and to a certain extent spleen, and also it will go to the fetal placenta. However, fetal placental stem cells doesn't have much physiological role. The liver and spleen will continue the process of hematopoiesis, and liver will continue its process, continue this process till birth. Bone marrows, which will start having this hematopoietic activity from the 4th month of intrauterine life, and after birth, these are the only sites which are going to produce the blood cells, at least under normal circumstances. Just after birth, all the bone marrows are active. That means all the bone marrows are red bone marrow. After puberty, it is limited only to the axial skeleton and the proximal parts of femur and humerus. And in adult life, 50% of the bone marrow are hematopoietically active. That means 50% are red bone marrow and 50% are yellow bone marrow. Those are inactive bone marrow. Okay. Now the same things, if we represent diagrammatically, you can see here the first cells you can find in the yolk sac. Next, it's the mesoderm, which is not shown in this image. And in the 2nd trimester, predominantly liver and the spleen that are going to produce the cells. Then bone marrow, it will start its function in the 4th month of life, and after birth, it is all about the bone marrows. Initially, all the bone marrows are active. Gradually, the appendicular skeletons will lose the property, and ultimately, the hematopoietic activity is limited to the axial skeleton, which include the skull bones, vertebrae, ribs, hip bones, and also I told you it is the proximal parts of humerus and femur. They will also have the hematopoietic activity. Okay, and previously we have discussed about the concept of extramedullary hematopoiesis. Extramedullary hematopoiesis means hematopoiesis that is happening outside the bone marrow. Okay, how why this happens? This happens whenever there is an increased demand. Okay, whenever there is an increased demand for the blood cells, for example, in patients with hemolytic anemia, where the RBCs are destroyed in the peripheral blood, there is increased requirement of the erythropoiesis. And if these physiological sites are not able to meet the demands, they are not able to fulfill the demands. The areas outside the bone marrow, for example, the liver and spleen, and also the lymph nodes, they will start having the process of hematopoiesis, and that is why in patients with extramedullary hematopoiesis, we are going to get hepatosplenomegaly and lymphadenopathy. And we have also discussed whenever there is increased bone marrow activity, you can find expansion of the marrow spaces, and in the skull, they produce the characteristic crew cut appearance. Okay, so these concepts we have already discussed in the previous lectures. Okay, one more point is I have told you in the infants we prefer doing bone marrow from the tibial bones. Okay, because that is convenient, and in the infants, tibia, the tibia bone will also have a significant amount of hematopoietic activity. Okay, and in adults, we prefer doing bone marrow from the pelvic bones, especially the iliac bone, and sometimes from the sternum also. Okay, I'll discuss these things again in the subsequent slides. Okay, so this is about the sites of normal hematopoiesis. Now we'll see what is the process of hematopoiesis. So everything starts from the hematopoietic stem cell. Okay. So if you see this hierarchical arrangement, the first cell is hematopoietic stem cell. And hematopoietic stem cells have two very, very important properties. I mean, these are not only for hematopoietic stem cells, these properties are for all the stem cells. What are those two properties? One is pluripotency, and the second one is property of self-renewal. What do you mean by pluripotency? Pluripotency means a single cell, a single stem cell can differentiate, and ultimately it can produce all the types of hematopoietic stem cell. All the types of mature hematopoietic cells. Okay, so a single stem cell can differentiate, diverge into various lineages. Ultimately, it can produce all the types of blood cells. So that is known as the property of pluripotency. The second property is property of self-renewal. Property of self-renewal means it is the process by which hematopoietic stem cells are able to maintain their cell population. So if you see, this is a hematopoietic stem cell. When it differentiate, for example, it will differentiate or it will divide into two cells. One cell will further differentiate and it will ultimately produce the mature blood cell. And the other daughter cell, this will contribute to the hematopoietic stem cell population. It will contribute to the hematopoietic stem cell population. So whenever they divide, 50% of the divided cells will go for further differentiation to become mature cells, and 50% of the cells will retain the property of hematopoietic stem cells. Okay, so that is how they are able to maintain their population. Okay, so these are the two properties, pluripotency and self-renewal. These two properties are seen in hematopoietic stem cells. Hematopoietic stem cells will differentiate into multipotent progenitors. They will also have this property of self-renewal. But once they go into various committed lineages, those committed cells will not have the property of self-renewal. Okay, those cells will only differentiate into a particular cell lineage. Okay, so these two are included in the stem cells. Then we'll see what are the committed precursors. Now these multipotent progenitors, they can be divided into two lineages. One is the myeloid lineage, other one is the lymphoid lineage. Okay, so the first cell is, this is early precursor, EP, early precursor of lymphoid lineage. So early precursor of lymphoid lineage, and this one is early precursor of myeloid lineage. Okay, so this early precursor of lymphoid lineage will ultimately give rise to all the lymphoid lineage cells, and early precursor of myeloid lineage will give rise to all the cells of myeloid lineage. Now this precursor of lymphoid lineage will give rise to pro-NK cells, pro-B cells, and pro-T cells. These will again differentiate to pre-NK cells, pre-B cells, and pre-T cells. Okay, and these are actually committed precursors. All these are committed precursors. Okay, and they will not have the property of self-renewal, and also they will not have the property of pluripotency. They can only differentiate into a single lineage. Okay, so pro-NK cells will give rise to pre-NK cells, which will ultimately give rise to NK cells, which you can find in the peripheral blood. Okay, these are the mature forms. Pre-B cells will give rise to the B cells, and pre-T cells will give rise to the T cells. Of course, there are various intermediate steps and there are various maturation steps. All those things I have not discussed here. This is just a simplified, you can say simplified diagram for better understanding. When we will discuss about the lymphoid neoplasms, we will again come to this and we will discuss a little bit more in details about all these things. Okay. So lymphoid lineage will give rise to the NK cells, B cells, and T cells. Now coming to the myeloid lineage. The early precursor of myeloid lineage, it will further divide into various colony forming units. Okay. Again, through various steps, it will make various colony forming units, and those colony forming units will differentiate into a particular lineage to give a particular type of mature cell. Okay, so these colony forming units can be colony forming units for granulocytes, colony forming units for monocytes, colony forming units for eosinophils, colony forming units for basophils, colony forming units for megakaryocytes, colony forming units for erythropoiesis. Okay, so these are the various colony forming units. We have already discussed in detail about the erythroid lineage, I mean the process of erythropoiesis. So this erythroid lineage we have already discussed. The colony forming units for erythropoiesis, they will give rise to the erythroblasts, and through various steps, they will ultimately give rise to the RBCs, which we are going to see in the peripheral blood. Okay, so this we have already discussed in detail. Then the colony forming unit for megakaryocytes, this will differentiate into the mature megakaryocytes, megakaryoblast, then the megakaryocytes. And ultimately, these megakaryocytes, they are cytoplasmic fragmentations. They will produce the platelets. So these are the platelets. Okay. And this process of megakaryopoiesis, this also we have discussed previously when we discussed about the platelets. Okay. Now, whatever is left is known as granulocyte monocyte lineage. So in this broad heading of myeloid lineage, if you separate this erythroid lineage and megakaryocyte lineage, whatever is left, these are known as the granulocyte monocyte lineage. Okay, actually, even if the erythroid lineage and the megakaryocyte lineage, they belong to the myeloid lineage, for the sake of simplification, whenever we discuss about the myeloid lineage, most of the times we refer to the granulocyte monocyte lineage. Okay, so this is a concept which you need to understand. Okay, so even though, I will repeat it again, even though erythroid lineage and megakaryocyte lineage, they belong to the myeloid lineage, for the sake of simplification, most of the times when we tell the myeloid lineage, we refer to the granulocyte monocyte lineage. So that is why when I told you that in the normally in the bone marrow, the myeloid to erythroid ratio is 3:1. In this, myeloid means I'm referring to the granulocyte monocyte lineage and not including the erythrocytes here. I mean the erythroid lineage here. Okay, so I hope this concept is clear. Okay, now we see what are the cells that are going to produce from the granulocyte monocyte lineage. Okay, so from this lineage, we'll have the granulocytes. Granulocytes include neutrophil. This include neutrophil, eosinophils, and the basophils. These are the granulocytes because you can appreciate the granules in these cells in the cytoplasm. So we'll appreciate the granules. Okay, so neutrophils, eosinophils, basophils. And we also have the monocyte, which is thought to be agranular. However, they have granules, but those granules are not easily stained. And in the under microscope, these are difficult to find the granules in the monocyte cytoplasm. Even though they have granules, those are not easily stained. So that is why it is different. It is told to be agranular. Okay, so these are the ultimate cells. So basically, the colony forming units for granulocytes, it will produce the myeloblast, which through various steps will give rise to the neutrophils. Monoblast will give rise to monocytes. Eosinophiloblast, this will give rise to the eosinophils, and basophiloblast, this will give rise to the basophils. Of course, there are various intermediate steps which I have not shown here, which I will discuss when I will discuss about the individual entities, like when we discussed for erythropoiesis, when we discussed about erythropoiesis, like and we also discussed about the process of megakaryopoiesis. Okay. Similarly, we'll also discuss about the myeloid, the process of myelopoiesis. We'll discuss a little bit more details. Okay. So this is just a very simplified hierarchical model for the process of normal hematopoiesis, and these are the blood cells that we are going to find. Okay. One more thing is, I have told you these monocytes, when they go from the circulation into the tissues, they will produce the tissue macrophages. And previously, I have told you some of the yolk sac cells will also become the permanent tissue macrophages. Okay, and there is one more cell, basophil-like cell, which is found in the tissues, that is known as Merz cells. Okay, Merz cells. So Merz cells are the cells which are exactly similar to basophils. They will have similar appearance. They will have the same properties, same surface, receptors, but the only difference is basophils are found in the circulation, mast cells are found in the tissues. Okay, now we'll add some important information here. Now we'll see what are the growth factors which are required for various lineage cells. I'll not discuss about the lymphoid lineage, that we'll discuss later. If you see the myeloid lineage, okay, first of all, we'll see what are the growth factors that helps in growth of the stem cells. Especially there are two important growth factors. One is the stem cell factor, which is otherwise known as the KIT ligand, and FLT3 ligand. FLT3 ligand. These are the two growth factors. These are the two growth factors which are required for the stem cells, and early precursor cells. Okay, these are required for the stem cells and the early precursor cells. Okay, for the myeloid lineage, we have GM-CSF. GM-CSF is growth factor for the myeloid lineage, the entire myeloid lineage. And there is something known as interleukin-3. Interleukin-3, this is growth factor for both stem cells and also for the myeloid lineage. Okay, so stem cell factor and FLT3 ligand, these are for the stem cells and early precursor cells. GM-CSF for the myeloid lineage, interleukin-3 for both stem cells and myeloid lineage. Beyond this, we also have various growth factors for individual myeloid lineages. For example, for erythropoiesis, we have erythropoietin. This we have already discussed. For megakaryopoiesis, megakaryocyte lineage, we have thrombopoietin. Thrombopoietin comes from the liver to a certain lesser extent from the kidney also. Erythropoietin comes predominantly from the kidney, and in a very minute amount, it can also come from the liver. Okay. For granulocytes, especially for the neutrophils, in this lineage, we have GCSF. For monocytes, we have MCSF, monocyte colony stimulating factor. For eosinophils, we have interleukin-5, which is the growth factor for the eosinophil lineage. Okay, for basophilic lineage, we are not very sure what exactly is the growth factor. So these are the various growth factors. We have certain common growth factors, and we also have certain lineage specific growth factors. Okay, so these are the important growth factors that we have to remember. Okay, so this is about the normal erythropoiesis, normal hematopoiesis, the hierarchy of normal hematopoiesis in a very simplified manner. Okay, more details we'll discuss when we'll discuss the individual entities, like we discussed when about the erythropoiesis and megakaryopoiesis. Okay. Now, if you see in the bone marrow, we have sinusoids. What are sinusoids? Sinusoids are actually a type of capillary. So these are actually specialized capillaries, which will have single layer of endothelial cell lining. This will have single layer of endothelial cells. Single layer of endothelial cells. As you can see here, these are the endothelial cells. Single line, single layer. This will have the basement membrane. This will have the basement membrane and the adventitial layer. So as you can see here, this is the basement membrane, and you can see this side, these are the adventitial cells. This basement membrane and adventitial cells, these are discontinuous. Okay, these are discontinuous. So we will find single layer of endothelial cells, and surrounding that we will find discontinuous basement membrane and the adventitial layer or the adventitial layer. Okay, now these are known as the sinusoids. So sinusoids are basically single layer endothelial cells with discontinuous basement membrane and adventitial layer. Why they have this certain openings in this basement membrane? Through these openings, actually, this megakaryocyte can project its cytoplasmic extensions. These are known as the pseudopores. Okay, so this we have discussed when we discussed about the megakaryopoiesis. When we discussed about the platelet formation. Actually, the megakaryocytes, when they extend their cytoplasmic processes into these sinusoids, sometimes these cytoplasmic processes can be fragmented, and these fragmented cytoplasmic processes will ultimately form the platelets. Okay, so inside these sinusoids, platelets will be formed, and these are nothing but the cytoplasmic fragments of the megakaryocytes. And these platelets can go from the sinusoids into the peripheral circulation. Actually, these sinusoids, these are continuous. These are continuous with the peripheral circulation. These are continuous with the peripheral circulation. So whatever cells, whatever hematopoietic cells that are being produced inside the bone marrow, ultimately it has to come to the sinusoids, and from these sinusoids it will go to the peripheral circulation. Okay, and from this you can understand that megakaryocytes are perisinusoidal in location. Usually megakaryocytes are perisinusoidal in location. Okay. Now, where you are going to find the erythroids? So erythroids are usually found in cluster. These are usually found in cluster surrounding a macrophage. As you can see here, these are the erythroid lineage cells which is surrounding a macrophages. Why it is important? Why it is important that these erythroid lineage cells should be present near the macrophages? Because we have discussed, whenever this erythroid lineage will mature, ultimately they have to give up their nucleus. Ultimately, the nucleus will come out of these erythroids. Those nucleus will be digested by the macrophages. Okay, those nucleus will be digested by the macrophages. So that is why erythroids are also are usually found near the macrophages. They are found in clusters surrounding a macrophage. Okay, and ultimately the mature erythrocyte, or you can say the reticulocyte, will come to the sinusoids, and from this sinusoid it will go into the circulation. Similarly, we also have the WBC lineage cells. When they will mature, they will also come into the sinusoids through transcellular pathway. Okay, as you can see here, through transcellular pathway, they will come to the sinusoids, and from these sinusoids, ultimately everything will go to the peripheral circulation. Okay. Along with these hematopoietic cells, we will also find empty spaces in the bone marrow. If you see the bone marrow slide, you will find various empty spaces. These are nothing but the fat cells. These are nothing but the fat cells. Okay. So we have the sinusoids, and the rest of the part is known as the interstitium. Interstitium is the area where you will find the hematopoietic cells along with the fat cells. But apart from this, we also have various stromal cells. Okay, so that I have not shown here actually. So you will also find various stromal cells. Now, stromal cells are very important. These are very important to maintain the stem cell niche. They are very important to maintain the stem cell niche. How? Because they will produce various growth factors. They'll produce various chemokines, cytokines, and certain adhesion molecules. This will help to protect the stem cells, and also they will nurture the stem cells. Okay, so they help in protecting and nurturing of the stem cells. Okay, so that is why these stromal cells are important. They will produce all the growth factors. So as I have told you, the process of hematopoiesis requires various growth factors. Okay, various growth factors, and all these growth factors are produced from the stromal cells that are there in the bone marrow, except the erythropoietin and the thrombopoietin. Okay, thrombopoietin and erythropoietin, they are not produced by the stromal cells into bone marrow. They are produced from the, I have told you, erythropoietin is produced from the kidney predominantly. Thrombopoietin is produced from the liver and kidney, but liver is the predominant site. Except these two, all other growth factors are produced from these stromal cells. Okay, and they help in maintaining this stem cell niche. This is because they produce the growth factors, chemokines, and adhesion molecules, which helps this keeping the stem cells in a particular location. And this is the property that we see when you do the hematopoietic stem cell transplantation. When you do transplantation, we give the stem cells. We give the stem cells to the recipient through the peripheral blood. Through the peripheral vein. These stem cells will circulate in the blood, and ultimately they will go and home in the bone marrow, because the bone marrow has these stromal cells which is maintaining the stem cell niche. Okay, and this will attract all the hematopoietic stem cells from the peripheral blood when you give the stem cells to the recipient blood. So that is how the hematopoietic stem cells from the circulation can go into the bone marrow. They can home the bone marrow in patients who have undergone hematopoietic stem cell transplantation. Okay, so that is why stromal cells are very important for maintenance of the hematopoietic stem cells in the bone marrow. When we do bone marrow examination, we do bone marrow aspiration and we do bone marrow biopsy. In aspiration, aspiration is good for looking for the morphology of the various hematopoietic cells. Okay, so this is important for the morphology. In bone marrow biopsy, we can comment on the activity of the bone marrow. How active is the bone marrow? We can comment in the bone marrow biopsy. So that is why when I discussed about the aplastic anemia, I have told you bone marrow biopsy is a must because we have to look for the cellularity. That is the activity of the bone marrow. Okay, so normally in adult, if the patient, if the adult is around 50 years of age, if it is 50 years of age, it will have 50% of cellularity and 50% of fat cells, 50% of the fat cells. That is 1:1 ratio. If the adult is around 50 years of age. Again, I will discuss a little bit on this in the next slide and how you will see for the cellularity and what is the normal cellularity of a person. Okay, so this is about the bone marrow histology. You can find the sinusoids, you can find the hematopoietic cells, you can find the fat cells, you can find the stromal cells, or otherwise known as the supporting cells. And also, when we see the bone marrow under microscope, we can appreciate the bony trabeculae. Okay, we can appreciate the bony trabeculae. So this is actually low power image. This is a bone marrow of a normal person. You can see these are the bony trabeculae, and you can see these are all the interstitium containing the hematopoietic cells, stromal cells, and you can appreciate the empty areas. Those are nothing but the fat. The adipocytes. Okay, the fat cells. Okay. From this, you cannot see the morphology of the cells. For that, you have to go to a little bit high power. Okay. And this is actually a bone marrow of patient with aplastic anemia. You can see there is severe reduction in cellularity. Only you can appreciate the empty spaces. Only you can appreciate the empty spaces. How will you look for the cellularity? So cellularity is, this I have also discussed when I discussed about the aplastic anemia. So cellularity is 100 minus fat spaces, 100 minus fat spaces. So that means in this bone marrow, the first bone marrow, the cellularity is somewhere around 70%. So fat, the fatty areas will be around 20 to 30%, maximum 30%. So 100 minus 30, that is 70%. So here cellularity is 70%. But in this case, in the second case, the cellularity will be around 20% because it is almost filled with the fatty areas. Okay. So this is how you look for the cellularity. And what is the normal cellularity of a person? So if a person is 30 years of age, the normal cellularity is 100 minus 30. That is 70%. That is 70%. So this is the normal cellularity of a 30-year-old person. Okay. And in a given bone marrow, you can identify the cellularity by this formula 100 minus fatty areas. That means this bone marrow, it's a normal bone marrow for a 30-year-old person, Okay. If I tell you that you are getting this kind of bone marrow in a person with 70 years of age, if you're getting this kind of bone marrow in a person with 70 years of age, then that means it is not normal. 70-year-old person should have a cellularity of only 30%. And in those persons, if you're finding this type of bone marrow, that means here the bone marrow is hyperactive. It is otherwise known as the hypercellular bone marrow, and that is pathological. Okay, hypercellular bone marrows are pathological. Hypocellular bone marrows are also pathological. And the normal cellularity is calculated in the bone marrow by this formula 100 minus fat. And normal cellularity for a given person is 100 minus the age. Okay, I hope this concept is clear. So hypocellular bone marrow you will find mostly in patients with aplastic anemia. And hypercellular bone marrow, there are various causes of hypercellular bone marrow. We'll discuss later. And it is usually seen in patients with myeloproliferative conditions. It can be seen in patients who have hemolytic anemia, where there is increased hematopoietic activity. So any condition with increased hematopoietic activity, we are going to find hypercellular bone marrow. Any condition with reduced hematopoietic activity, we are going to find the hypocellular bone marrow. Okay. So now we'll discuss what are the sites of normal bone marrow examination. So the most common site that we prefer is posterior superior iliac spine. Posterior superior iliac spine. That is the most common site in an adult that we do the bone marrow. But if sometimes in obese patients, it is difficult to appreciate, it is difficult to do the biopsy from the posterior superior iliac spine. In those cases, we can do the procedure from the anterior superior iliac spine. Okay, it is around 5 centimeter. It is around 5 centimeter behind the anterior superior iliac spine. The exact site is 5 centimeter posterior to the anterior superior iliac spine. Okay, so this is preferred whenever there is difficulty gaining access to the posterior superior iliac spine. For example, in patients who are obese, or they may have some infections in the back. So in those conditions, we can do it from the anterior superior iliac spine also. Okay. Then the next one is the sternum. Sternal procedures are usually, it is usually avoided because from the sternum, we cannot do bone marrow biopsy. So bone marrow biopsy is not done from the sternum. Only you can do bone marrow aspirate. Okay. So from sternum, you can only do bone marrow aspirate. For bone marrow biopsy, we have to go a little bit deep. Okay. So that is why it is avoided in sternum, because behind sternum, we have important mediastinal structures, including heart. So we do not do bone marrow biopsy from the sternum. We do only bone marrow aspirate. Though bone marrow aspirate is diagnostic for many of the conditions, okay, though bone marrow aspirate is diagnostic of various conditions, many conditions, we always tend to do aspirate and biopsy for all patients. Why? Because many times bone marrow aspirate is diluted with the peripheral blood, and sometimes the bone marrow, sometimes it will not produce that much yield when we do the bone marrow aspirate. That is known as the dry tap. Okay, so that is why we always do. Most of the times we do both bone marrow aspirate and biopsy. So that is why we usually prefer posterior superior iliac spine or anterior superior iliac spine, and we do not do it from the sternum, because from the sternum we cannot take the bone marrow biopsy. Okay, and I have told you in infants we prefer tibia bone for the bone marrow procedure. Previously, we used to study different needles for aspiration and different needles for biopsy, but currently we use Janssen needle for both aspiration and biopsy. Okay, so this is the preferred needle currently for both aspiration and biopsy. Okay, so these are the sites from where we do the examination. And this is how you can look for the normal bone marrow, a hypocellular bone marrow, and a hypercellular bone marrow. Okay, so this concept is also clear. The last thing is sometimes some abnormal cells can populate the bone marrow. They can infiltrate the bone marrow. Okay, this we have discussed when we discussed about the myelocystic anemia. That means space occupying lesion replacing the bone marrow, normal bone marrow elements. For example, malignant cells, granulomatous cells, or the spent phase, during spent phase of myeloproliferative neoplasms. There will be infiltration of the bone marrow and fibrosis of the bone marrow. And whenever there is fibrosis of the bone marrow, because of this abnormal population of the cells, it can push the normal developing hematopoietic cells into the peripheral blood. So in the peripheral blood, you can find the nucleated RBCs, immature granulocytes, and when the RBCs tend to come through the negotiate through these fibrotic areas, they will become teardrop cells, which are otherwise known as the dacrocytes. Okay, so in conditions whenever there is a bone marrow infiltration in the peripheral blood, we are going to find teardrop cells, teardrop RBCs, immature granulocytes, and the nucleated RBCs. So this is a nucleated RBC. These are the immature granulocytes, and you can see these are the teardrop red cells. Okay, so this is known as leukoerythroblastic blood picture, LEBP. Leukoerythroblastic blood picture. Okay, so this is all about the normal bone marrow morphology and about the normal hematopoiesis.